examination here in EVRMC, and then the vaccine is still to be prepared. So I have decided, because we have a relatively long lecture now, I will finish up the two topics this morning, so we can have the examination on Wednesday. Pero I'll be later kung ako na time para ma-injikan ako, we will have a break. Is it okay lang? Hello?
Yes po, Doc.
Okay, thank you. So, last time we discussed about the introductory part in mycology, and then I also discussed the cutaneous mycosis. So this time we will be dealing here with fungal infections that are caused by fungi, and then these are the infections that are located in the subcutaneous tissues, as well as those fungi that causes systemic mycosis. So to start with, we have the following these fungal diseases that affect the subcutaneous layer of your body. So we have the first one is sporotrichosis. This is described as a chronic infection of the cutaneous and subcutaneous tissues and the lymphatics. So the identified causative agent for this fungal infection is Sporoptrix shinki, and one can have this infection through traumatic inoculation in the skin. However, the infection is not only limited in the subcutaneous layer of your body, but it may have the tendency to spread to lymphatics, lymph nodes, muscle, and bones. And other organs may also be involved, like your lungs, CNS, and the GUT. Okay, so this is the morphological characteristics of Sporoptrix shinki. So when the organism is cultured in suborobes, this dextrose agar at room temperature, between 3 to 5 days, it produces the blackish to and shiny but become fuzzy with age colonies. So please take a look on the illustration on the monitor. So this is described as a dimorphic fungi, in which the yeast form can also be isolated at 35 to 37 degrees centigrade using the brain part infusion agar. Okay, so this is the microscopic appearance of Sporoptrix shinki. Okay, so what are the determinants of pathogenicity of Sporoptrix shinki in causing the disease? So it was described to be sensitive to temperature, so that this is also one reason by which the organism favors to be located in the subcutaneous tissues. Most strains grow at 38 degrees centigrade, and the possible mechanism for tissue tropism or specificity and its toxicity is related on the production of the enzyme neuraminidase. Okay, so with regards to the clinical manifestations of sporotrichosis, this affects all persons and ages. However, there is sex predominance, wherein it is observed to affect 75% of males because of the so-called sex-linked susceptibility. And of course, the increased exposure of the male gender in having the infections. But there are also identified factors for one to develop sporotrichosis. These include um, nutrition, alcohol, then gender, and low cell-mediated immunity. Okay, so there are clinical forms of sporotrichosis. We have the lymphocutaneous sporotrichosis, which comprise the most common type of the disease entity, wherein it affects 75% of the cases. And this is caused by traumatic inoculation on the skin. And the with the entry of the fungal organism in the subcutaneous tissues, it will involve now skin nodules formation as manifested on the illustration on the screen. Okay. The second type of sporotrichosis is the chronic one. So this also involve nodules development, and the initial lesion is said to be more exudative but less gomatous. And there is again the tendency to become chronic but may heal spontaneously. So again, it is classed on the monitor, an example of chronic sporotrichosis. Then the third type is the so-called fixed sporotrichosis. This refers to the presence of only one lesion. So the infection is said to be restrictive but less progressive. So the lesion is ulcerative and may appear as plaque or rash. So this is associated in endemic areas, the fixed sporotrichosis. So aside from the acute, chronic, and fixed, we have other forms of sporotrichosis affecting other tissues of our body, usually the mucocutaneous areas of like your eyes. It may also involve your bones, which is the most common site for dissemination from skin lesions, and in the meninges of your brain, which is said to be the most common site affected when the lesions now become metastatic. Okay, so these are the other forms of sporotrichosis. Okay, how do one diagnose sporotrichosis? First, you can do your microscopic examination through histopathology. So basically, the lesion resembles epithelioma. So one can use stain. So we have the PAS or the periodic acid shift stain and the methylamine silver stain. Okay. Then, of course, if you're dealing here with infections, the gold standard for the laboratory diagnosis is, of course, the culture. So you culture at room temperature, and then you use specific culture media like your Subrout's dextrose agar incorporated with a specific antibacterial antibiotics. This is for the purpose of inhibiting the growth of bacteria. Then we have also the inhibitory mode agar. So what are the different specimens submitted for culture? You can use aspirated fluid, and then you can also use pus, exudative material, and biopsy tissues. Okay. For rapid diagnosis, you can try doing your serology test. However, it is help only for early infection. So the for one serological test to be of diagnostic value, you need 1:80 titer to show significant reaction. When you say significant reaction, to consider the test as positive. So a titer of 1:80. Okay, so how do you treat sporotrichosis? So for cutaneous and fixed sporotrichosis, this is said to be non-debilitating disease. So one can the disease entity may not require treatment. However, please also remember that the lesions are said characterized to be chronic and may persist even without treatment for years. For cutaneous sporotrichosis, the treatment of choice is the use of potassium iodide. You can also try other antifungal agents like your stilbamidine, griseofulvin, and 5-fluorocytosine. Okay, so that is for sporotrichosis. The next fungal infection is chromomycosis or uh, hypomycosis. So chromomycosis and phaeohypomycosis. So the pathology behind these two disease entities is caused by traumatic implantation of dermatitious fungus into the subcutaneous tissue. What are the possible causative agents for these fungal infections? We have the Poinsettia pedrosi, which is the most common fungal organism isolated. Then we have Poinsettia compacta, then Phyllophora verrucosa, and Cladosporium caryon. So the natural reservoir of the infection are the soil and plant debris. So that is your chromomycosis. So characteristics to this fungal infection is it has low level of virulence, and it is described as a localized infection in the exposed lower extremities. And systemic invasion is relatively rare. So to your right of your monitor, this is an example of the lesion caused um, that is diagnosed to be chromomycosis. Okay, so what about phaeohypomycosis? So this refers to all infections characterized by the presence of darkly pigmented septate hyphae in tissue, both the cutaneous and systemic mycosis. So there are clinical forms of phaeohypomycosis. We have the encapsulated cyst, brain abscess, and mycetoma. Okay. So how do you diagnose the infection, fungal infection in the laboratory? You can do your potassium hydroxide preparation. So the potassium hydroxide preparation, or your KOH, just a simple wet mount. So you need the skin scraping, and then um, add your potassium hydroxide, and then you uh, examine it under the microscope. You can also do your tissue biopsy, and of course, do culture using again fungal specific culture media, like your Sabouraud's dextrose agar and Loeffler's serum agar. Okay, so from the illustration, you can have the tissue biopsy result, and then the B figure shows the colonial morphology of the organism, and figure C represents the microscopic appearance of the organism. Okay, so how do you treat the infection? So antibacterial agents are usually recommended if you are dealing here with complicated lesions. You can also do surgical drainage, then the use of topical agents like flucytosine, and then if you're dealing here with brain abscesses caused by the infection, by the fungal organism, it is warranted to do brain surgery. And then the with surgical management, this is coupled here with the use of antifungal agents like amphotericin B, flucytosine, miconazole, and ketonazole. Okay. Next is mycetoma, or the other terms include Madura foot or Maduromycosis. So this is described as a chronic subcutaneous infection induced by traumatic inoculation with any saprophytic fungal organisms. So basically, there is no specific organism, fungal organism that is that can be uh, pointed as the cause of this mycetoma. So mycetoma is not exclusively caused by fungal organisms, but bacteria as well. So we have this differential um, or agents that may cause mycetoma. Okay, so what are the most commonly affected body parts in mycetoma? So these include your feet or the lower extremities. So as exemplified in the illustration, in the as exemplified in the picture on your right side of your monitor, and then hands, and then also exposed skin. So pathology-wise, this mycetoma is characterized by suppuration and abscess formation. There is also granulomata and formation of draining sinuses containing granules or microcolonies of the fungi. It is said to be chronic in nature, and the risk for dissemination is said to be minimal. Okay, so how do you diagnose and as well as treat the mycetoma? So this involves demonstration of the granule, the color texture, the size and presence of um, hyaline or pigmented hyphae that will help us determine the specific etiology. So treatment is said to be difficult, but you can try the following antifungal agents, and these include amphotericin B. You can use also topical nystatin, potassium iodine, flucytosine, and then surgery may be warranted in protracted cases that are said to be unresponsive to medical conservative management. Okay. Next, we have rhinosporidiosis. So this is a chronic infection characterized by the development of polypoid buses in the nasal mucosa. And the causative agent for this, the fungal agent, this rhinosporidiosis is caused by um, Phonosporidium severi. So this is a zoonotic disease that are common in horses, cattle, and dogs. So this infection is said to be common in children and young adults. And it was being found out that most males are commonly infected, comprising about 90% of the cases. So in figure A, it will show to us the gross lesion affecting the nose twigs. And then figure B will tell us the histopath result of the mass. Okay, so the lesions are most common in the mucosa of the nose, nasopharynx, and soft palate. Okay. And then the mucocutaneous tissues are also affected, involving your conjunctivae, the skin, the larynx, genitalia, or even the rectum. Okay. For the diagnosis and treatment of the fungal infection usually include histologic examinations, and for rapid diagnosis, you can try serological tests. Treatment includes surgery and the use of topical agents and local injection with ethyl still being meeting. Okay, the next is lobomycosis. So this is a chronic subcutaneous infections in humans, and the lesion is called lobomycosis because of the causative agent Loboa loboi. So the clinical manifestations of this fungal infection include the appearance or formation of hard nodule in the extremities, face, and ear. So the laboratory diagnosis include direct microscopic exam of skin scrapings, biopsies, wet mount of the lesions. And then treatment include the use of sulfa drugs, and of course, if there is a need to do surgery, surgical excision. Okay, so these are examples of how lobomycosis look like. So figures A and B that's the gross appearance of the lesion, whereas figure C is the histopath result. Next, we have Amo na liwat init makuri himin nga rhinointomycosis. So you need really to pronounce this and verbalize the term so you can be used to this. Rhinointomycosis. So this is said to be a rare infection of the nasal mucosa, and this is caused specifically by Conidiobolus coronatus. So this involved culture of the organism in Sabouraud's dextrose agar, and when cultured in this culture medium, you can see fast-growing colorless to yellowish colonies, and clinically, it presents as nodule formation. Oo, oo, okay. Pwede mag-break na kita kay ako na sunod-sunod. Okay la?
Yes
Okay
po,
po
Doc.
daw.
Sorry ha, sorry. Di rin man na maiha kay kuan man nini Pfizer. So dapat kasi adto pagud dayon. Okay? So I'll continue the lecture once maka-receive dayon na akon vaccine. Okay?
Okay
So
po,
you can
Doc.
have first your break.
Okay daw. Hello, magpa-attendance na lang ako, Lorraine pa. Thank you.
Okay, I'm back. Hello, ada pa ka mo?
Hello, Doc.
Yes,
Yes
ma'am.
po.
Ay, no. Amo nga ako, amo maris yun, no, doktor kita tapos nahadlok kitang dagong gihapon. Tapos na. Ayan, nagaham. Yan ay nagahangit akong slide. Okay. Okay. So, going back to our subcutaneous mycosis, the next is subcutaneous Mycoses. This is a chronic condition, but said to be self-limiting. So the fungal agent responsible for this infection is Basidiobulus haptosporus. So the infection is most prevalent in Africa, especially among children, affecting usually more males. So the lesions start as a nodule in the torso or in the limb. So laboratory diagnosis involve culture again in SDA or subroutes, dextrose agar without cycloheximide. So treatment is with the use of potassium iodide, and the prognosis is said to be good. Okay. Do you have any questions with regards to the subcutaneous mycosis? The next topic involved the discussion of fungal infections, which may involve the systemic. So, meaning there is a involvement of organs. Okay, so we have the systemic mycosis. First is First is Coccygeal Domicosis. This is caused by Coccygeoides immitis, and one can have the infection through inhalation of arthroponedia. So, with regards to the clinical pathology of the lesion, this may present as a delayed type of hypersensitivity reaction. So half of the cases are described to be benign, symptomatic, but self-limiting. So what are the predisposing factors for one to develop the disseminated coccygeal Domicosis. So one is the race. So this is said to be common in among Blacks, in Filipinos, Latin Americans, and Indians. Okay, so with regards to coccidioidomycosis, there are clinical forms. The first one is primary coccidioidomycosis. This follows inhalation of the arthropomedia except for cutaneous inoculation. So most of the cases are said to be again asymptomatic. However, if the patient is symptomatic, the clinical signs include fever production, chest pain, cough, weight loss. So diagnostic, the X-ray will show discrete nodules in the lower lobes of the lungs. Other signs and symptoms include allergic reactions, usually erythema nodosum or multiforme. So for the primary coccidioidomycosis, it is said to be of good prognosis. The second clinical form is the disseminated coccidioidomycosis. So usually this develops within a few months as a complication of the primary infection. So we have the under this disseminated, we have clinical types. We have the chronic and progressive pulmonary disease, then single or multiple extrapulmonary dissemination, which include now involvement of the meninges of the brain, skin, or bones. And then the third type of disseminated coccidioidomycosis is the generalized type. So in the illustration, in the figure, especially the figure in the lower portion, it shows the involvement of the spine. Okay, so how do you diagnose coccidioides immitis in the laboratory? So please take note that the fungal organism is said to be dimorphic, and the definitive for definitive diagnosis, this requires demonstration of granules in sputum, in draining sinuses, or tissue specimens. You can do this, the demonstration of these granules through potassium hydroxide malt. You can also do culture using SDA supplemented with 4% glucose and the use of inhibitory mold agars. You can also do for preliminary diagnosis using some serological tests like complement fixation test, the tube Pristin test, and immunodiffusion test. Okay, so this figure will show to us the on your leftmost part is the surface growth of the organism, showing the colonial morphology. Then in the middle, it will show to us the microscopic morphology of the organism, and the rightmost figure shows the histopath. Okay, so for the infection, for treatment, it requires simple symptomatic treatment. So meaning, based on the symptomatology presented by the patient, you just give medications according to how the patient present himself. So you can also use antifungal agents for severe primary infection with dissemination using amphotericin B. Then antifungal agents, miconazole, and also for coccygeal meningitis, you can use intrathecal chemotherapy. And then also you can try the use of ketoconazole. Next, systemic fungal infection is histoplasmosis. So this is the most common pulmonary mycosis of humans. And the culprit agent for this is Histoplasma capsulatum, which is also characterized to be a dimorphic fungi. So the infection is initiated primarily through inhalation. But other modes of transmission can also be possible through using vectors like bat. Okay, so we'll now go to the clinical manifestation of histoplasmosis. So we have the so-called acute pulmonary histoplasmosis. This presents as a flu-like illness developing to moderate to severe disease. So the degree of involvement and symptomatology is related to the size of the inoculum inhaled. So it requires an incubation period of about 1 to several weeks, and usually the patient presents with fever, night sweats, dyspnea, hoarseness of voice, and weight loss. So the figure will tell us the X-ray result of patients having acute pulmonary histoplasmosis. The second clinical type is chronic pulmonary histoplasmosis. Most the gender that is most commonly affected are the adult men. So the signs and symptoms presented by the patient may be indistinguishable from chronic cavitary TB. So this will tell us that the chronic pulmonary histoplasmosis can be confused with that of TB. So the clinical manifestations include fever, productive cough, progressive weakness, and fatigue. Okay. The third clinical form of histoplasmosis is the disseminated one. So we have the disseminated histoplasmosis. So after the lungs, the most commonly affected are the reticuloendothelial tissues of the spleen, liver, lymph nodes, and bone marrows. It may be benign and inapparent infection, and in some cases, it may be acute and progressive. So signs and symptoms include enlargement of the spleen and as well as the liver. There could also be weight loss, anemia, and leukopenia. Then another clinical form is primary cutaneous histoplasmosis, but this occur rarely, and one can have the infection through contamination of the traumatic wound. So for histoplasmosis, the laboratory diagnosis include the following. You can do your fungal smear using the following specimens: sputum, tissues from biopsy, spinal fluid, or even blood. So aside from having the smear, you can do culture using the following specimens: sputum, bronchial washings, and then you can use the Saboral's dextrose agar supplemented with cyclohexamide, chloramphenicol, or gentamicin. So you should be careful in when you do your culture. Kailangan mo usually for culture of fungal organism, we require only 2 weeks. But here, if you are dealing here with Histoplasma capsulatum, the incubation required is 4 weeks at temperature between 25 to 30 degrees centigrade. Okay, so this is how Histoplasma capsulatum looks like on culture. So the figure on your left, so describing the colonial morphology, and then on the right side is the microscopic appearance of Histoplasma capsulatum. You can also do serological tests using complement fixation test and immunodiffusion test. For treatment, most cases remain undetected and require no treatment. So the treatment of choice for full-blown infection is amphotericin B. Surgery may also be warranted in some cases. Okay, next is blastomycosis. This is described as a chronic infection characterized by granulomatous and suppurative lesions initiated by inhalation. So the causative agent is blastomyces dermatitidis. So the primary organ that is involved are the lungs, but there might be the tendency of the infection to be disseminated to other organs. Okay, so there are two clinical forms of blastomycosis. We have the pulmonary and the chronic cutaneous blastomycosis. So the first one involving the lungs, the second one, the chronic type, involving your skin. So for pulmonary blastomycosis, it may be asymptomatic or present as an acute or subacute pneumonia. So it persists locally in the lungs, but may spread to any organ. So the lesions rarely castrate or calcify. It may be disseminated through the lymphatic or blood circulation. So the most common forms of lung involvement involves infiltration, cavitation, pneumonia, or formation of nodules. Okay, then we have the chronic cutaneous blastomycosis. So the initial lesions are described as one or more subcutaneous nodules that ulcerate. So the lesions are common on the exposed skin surfaces, such as the face, the hands, wrist, and lower leg. And there is also the tendency for the lesion to extend into the trunks. Then we have the disseminated blastomycosis. This is an extension of the pulmonary blastomycosis. This involves the skin, the bones, the GUT, the central nervous system, and spleen. Less commonly affected are the liver, lymph nodes, heart, and the visceral organs. Okay, so for the diagnosis, you can do your KOH or potassium hydroxide preparation using pus, exudates, and sputum as the specimen. Then you can also do culture using SDA, inhibitory mold agar, or the sheep blood enriched medium. And also, you can use serology for rapid diagnosis using tests involving the use of complement fixation test. Okay, so this is how blastomyces dermatitidis looks like on culture. So that's the surface growth. And then on the right side of the figure is the microscopic morphology as you view this in the microscope, showing hyphal elements with macroconidia. Okay, so for treatment, you can do use aromatic diamidine, amphotericin B, and ketoconazole. Okay, next is Paracoccioide Domicosis. This is described as a chronic granulomatous disease that begins as a primary pulmonary in apparent infection that disseminates to produce ulcerative granulomata in the mucosal surfaces of the nose, mouth, or GIT. So the figure here will show to us involvement of the oral cavity. So the causative agent for this infection is Paracoccioides brasiliensis. So this is also a dimorphic fungal agent. So we have clinical forms. We have the asymptomatic infection, which is responsible for the initial establishment of the infection in humans. And then the second one is the latent or residual form. Then the second group are the symptomatic disease. These include the juvenile type and the adult type. So the juvenile type is described as either acute or subacute and progressive form. For the adult type, we have the chronic progressive form, which may involve pulmonary or the disseminated infection. Okay. Laboratory diagnosis for this fungal infection includes microscopic examination using the following specimens. So we have sputum, tissue, or scrapings from the mucocutaneous lesions. You can also do culture using SDA or Pseudomonas dextrose agar incorporated with antibiotics as inhibitors for bacterial organisms, and then brain heart infusions. Then we have the serological test like immunodiffusion test and complement fixation test. Okay, so this is how your Paracoccioides brasiliensis look like. So the figure A show to us the colonial morphology upon culture. Then figure B and the figure on the right will show to us the microscopic appearance of Paracoccioides brasiliensis. Okay, so for treatment, this involved the use of ketoconazole, labeled as the drug of choice in the treatment of the infection. But you can also try amphotericin B and sulfa drugs. So for one to consider that there is success in the treatment, it requires about 2 years to treat the patient. Okay, the last group of infections are the so-called opportunistic mycosis. Opportunistic mycosis. So these are fungal infections which are relatively non that is relatively benign, but when the immunity of the host is compromised, then it becomes pathologic. Okay, one is candidiasis. So, of course, you know it already that the causative agent is albicans. So, Candida albicans grow in several different morphological forms, and it is described as unicellular, oval-shaped fungus, and it live as a harmless commensals in the gastrointestinal and genitourinary tracts, and are found in over 70% of the population. So meaning the Candida albicans may be non-pathologic in some cases. But the organism is said to be dangerous when there is already overgrowth of the organism. Okay, so this is your Candida albicans. To your left is the schematic representation of the microscopic morphology. And then on to your right are the different organ systems in your body that are susceptible for candidiasis to develop. Okay, so this slide will just show to us how varied is the presentation of candidiasis. So you can have many symptoms observed in the patient. So from nausea to formation of low-grade fever, even development of food allergies. So varied the presentation for candidiasis. Okay, so what are the predisposing factors for one to develop candidiasis? So immunocompromised state. So, di ba? I mentioned it earlier that the organism is just opportunistic, but when there is compromise already in the immune system of the patient, then it can cause disease. For also other predisposing factors include prolonged use of antibiotics, anti-cancer drugs, and anti-inflammatory drugs. Another predisposing factor is having low birth weight neonates, and for those undergoing therapeutic procedures like organ transplantation, open heart surgery, and then artificial heart valves, those having indwelling catheters are susceptible for the development of candidiasis, and also in burn patients. Okay, so the candidiasis is classified into cutaneous and systemic. So, sabihin ko pa, there are many, for systemic, there are many organs that are affected. So, depending on organ affected, so you can have esophagitis, then arthritis, endocarditis, so down the line. So, kay varied niya presentation, varied liwatan niya, and organs affected. Okay, so this is how your Candida albicans look like on culture and then on microscopic examination. So for the laboratory diagnosis, you can use the following specimens. So it is according to the site of lesion, like using now exudates, vaginal, oral swab, tissue, and nail scar, scrub, then blood. So you can do microscopic examination using stain smears or wet mount using potassium hydroxide. Okay. So you can also do the following test: germ tube test, then culture in cornmeal agar, wherein it will show production of chlamydospores, and do also doing resistance to 500 microgram of cyclohexamide. So when you get these tests positive, these 3 tests positive, then you are sure enough that you are dealing here with Candida albicans. If negative, then it could be other types of yeast. Okay, so this is how the biochemical tests are included in identifying your candida. So na-mention man earlier natin germ tube test, then also chlamydospore formation using a specific agar. Then please take note that with regards to sugar fermentation, Candida albicans is capable of fermenting glucose and maltose. And then also another biochemical reaction is inoculation of the yeast to the chromogenic agar. Okay, for treatment, so you can have either you are dealing here with a localized infection or a systemic infection. So you can use for for dealing here with localized infections, you can use, especially involving the skin, you can have the topic topical preparations. And then for systemic, you can use the IV drugs, antifungal agents. Okay. Then another opportunistic mycosis is cryptococcosis. So please take note, wrong spelling. There should be letter P. So it's spelled as cryptococcosis. May CRYP. Yan. So the causative agent is Cryptococcus neoformans. It is abundant in feces of pigeons. So kung hinot-damot sarapati, be careful because this Cryptococcus neoformans is contained in the feces of pigeons. So with regards to morphology, this is described as spherical budding cell with capsules. So the source of infection is through inhalation of dust containing now the yeast cells. So diri gid ano to sayop itong pag-alaga ng mga sarapati, but make sure that the ano to, burutangan nimot imo mga sarapati mag-infuse. Okay, so with regards to pathogenesis in the production of the infection, so it starts in the molecular level down to the organismal level. So very from the molecular level to cellular, then um, tissue level, then to the organ involvement. Okay, so with regards to the infection, these are some of the symptoms presented by by the patient. So the most common is having cough, but there are also patients that will present with weight loss, fever, dysphonia. Sorry, this should be dyspnea, not dysphonia. Dyspnea, thoracic pain, headache, and hemoptysis, or coughing out of blood. Okay, so for the laboratory diagnosis, these are the specimens that can be used. We have the CSF, sputum, then lymph node aspiration, biopsy, then blood, urine, and express prostatic secretion. So this also involved the demonstration of encapsulated budding round yeast in a sterile body using India preparation or histopathology. So the India ink technique is used to demonstrate the capsule produced by Cryptococcus neoformans. You can also do culture and then detection of cryptococcal capsular antigen through serology. Okay, so this is how your Cryptococcus neoformans look like on culture. Okay, here naman ang microscopic appearance of the Cryptococcus neoformans. Okay, then you can also do serological tests for the identification. Okay, so for Cryptococcus neoformans, it is negative with germ tube test, then urease positive for 3 hours. Then you can also do biochemical test using phenol oxidase enzyme test and urease test. Okay. For treatment, so in for meningitis, this involve treatment phase and maintenance phase. So it requires about 2 weeks for amphotericin B, or if you are after amphotericin B, you can use now fluconazole for for about 10 weeks, and then after 10 weeks you can continue the fluconazole at a different dose for the maintenance phase of the treatment. Okay, so it also differ the treatment also differ with regards to the immune status of the patient. So for immune competent, meaning the immune system is still good, so you can use fluconazole and itraconazole. For the deficient patients, you can do amphotericin B or flucytosine. Part of the prevention is avoid contact with birds. Next, we have aspergillosis. So, aspergillosis is an allergic pulmonary disorder caused by hypersensitivity reaction to Aspergillus pyovigatus So it occurs as an asthma or in asthma or cystic fibrosis. So this result in the immune response to our Aspergillus, colonization of airway, and poor clearance of mucous secretions. So this can be manifested as bronchiectasis, pulmonary fibrosis, and compromise now the pulmonary function. So these are the clinical forms of aspergillosis, from the allergic bronchopulmonary aspergillosis to chronic one, allergic or, aspergillus sinusitis, then also aspergilloma. Then we have the invasive aspergillosis, cutaneous. Then you can have also exacerbation of asthma and also exacerbation of COPD or chronic obstructive lung disease. So what are the risk factors for one to develop aspergillosis? So one is a weak immune system. And then for those patients undergoing organ transplantation and those having chemotherapy or malignancy. Okay, so these are the risk factors for the invasive pulmonary aspergillosis. So you can have a prolonged neutropenia, so there is an absolute decrease in the neutrophils. Then in cases of corticosteroid therapy, especially for those post-transplant patients, and those that immunocompromised patients, then hematologic malignancy, then those that received cytotoxic therapy, and the aged patients. Okay, so these are the signs and symptoms of aspergillosis. So it depends upon what organ, but basically it primarily affects the lungs. Pero there are also other organs that are involved. Okay, for laboratory diagnosis, you can do your microscopy using stain, and then of course you can do culture. So we have some species of aspergillus with the characteristic color of the colonies. So for aspergillus fumigatus, it produces green colonies. For Niger, it produces black colonies. For Aspergillus flavus, it has yellow colonies, and Aspergillus tertius, so it produces brown colonies. Okay, so I'm with Mia. So in the upper part of the upper portion of the figures, describe the describe the colonial morphology, whereas the lower group of figures show to us the characteristic microscopic appearance of the organism. Okay. So for treatment, so we have this. This table will also tell us the different species of Aspergillus, and then the specific part of the pathway that is affected by the treatment, and then the current drugs that are applicable for the use of in the treatment of the infection, and The last column will tell us the limitations of the said medications. Okay, that's it for the um, mycology. Do you have any questions? Do you have any questions?